Welcome to AETCM, the Emergency Medicine Channel.
Yes.
So, presenting the case of a 40-year-old female who presented to ER with complaints of multiple episodes of vomiting since last 4 days, along with constipation since the last 2 days, and also presented with tingling sensation all the body. On initial 10-second assessment, the airway was patent. The patient was talking in full sentences. There was no presence of any pooling of secretions or stridor. Breathing, the respiratory rate was around 17 per minute. Saturation of 98% in room air. Chest was clear and air entry was bilaterally equal. Circulation, BP was 100/70 millimeters of mercury. Heart rate of 90 per minute with a capillary refill time of 3 seconds. And disability was E4, V5, M6 and GRBS of 100 milligram per deciliter. And exposure, the temperature was febrile, there was no presence of any rashes. As a part of adjuncts to the primary survey, we initially took a VBG, which is showing a metabolic alkalosis with a pH of 7.58 and bicarbonate.
Normally, hypokalemia, what will happen to the ABG values?
Hypokalemia, presence of alkalosis will be.
So, alkalosis can produce hypokalemia. Hypokalemia can produce alkalosis. Which hypokalemia condition can have acidosis?
Renal tubular acidosis.
One category of renal tubular acidosis can have acidosis. Otherwise, almost all hypokalemia cases you are expecting alkalotic pH.
And with the potassium of 2.2 and sodium of 130.
Okay. What is the deficit of potassium in that patient's body? How do you calculate it? Can you calculate potassium deficit from the potassium levels? So that is very important. You have to see the amount.
60%. For male, 60.
0.3 milliequivalents is equal to 100 milliequivalents in body. That much deficit will be there. So this will be 2.8, no? 2.8, 2.2. So 0.3 is around 200 deficit is there.
Yes.
So that we should know because we are going to correct it.
Yes.
We should know how much to correct and what is the importance of correction during correction. Why we should know that 200, 300 or 100. What is the importance of this?
So in case of.
What is the importance? The 200 deficit is there. In 24 hours you have to correct it.
So that there's a transcellular shifts and everything.
Correction. How much to give? In 24 hours fluid and
How much potassium to give as correction depends on the deficit of.
How many should answer?
Once again.
See, now 200 deficit is there.
Yes.
Patient is having alkalosis. So you have to correct it over the first 24 hours. What is the first step you do? Central line. So this patient may require a central line. That is very important. This patient, we cannot give this 200 milligram milliequivalents over the peripheral line. So that we should remember. Okay.
Yes. And we initially took a ECG also. There was a presence of U wave was present in the ECG.
What is UV?
So this presence of depolarization. Depolarization.
So what, in the ECG, how it appears?
There will be another positive
wave?
after
After
T wave.
T wave, in which all leads? Which all leads? U waves are very prominent in which all leads?
2 and V2.
V2, V3, V4. Anterior chest leads.
Chest leads.
Okay.
And
So you should know all these things. When you are presenting a case, I am expecting that you are reading like a consultant. You should know. Otherwise, I had to read and I had to tell everything.
And patient had we took a CBC CRP showing a total counts of 7,900 with a HB of 9.6, platelet count of 2,09,000 and CRP of 10. And we moved
Hemoglobin has got any value in potassium levels? Hemoglobin.
correction of like megaloblastic anemia correction time patient can develop hypokalemia.
Okay, hemolysis.
Hemolysis.
So hemolysis, especially when you are taking the sample,
Yes.
that has got it can increase the potassium or decrease in potassium is not known, but it can increase the potassium.
Yes. So sample history, 40-year-old female, known case of type 2 diabetes, hypertension, presented to ER with complaints of multiple...
Hypertension and hypokalemia.
Yes.
What is your possibility? What are your possibilities? Hypotension, hypertension and hypokalemia.
So hypertension, if patient is having a hyperaldosteronism.
Sure. All patients with hypertension with hypokalemia. First diagnosis hyperaldosteronism.
No, if patient could be using a medication like Lasix,
So the
diuretics.
most common thing is hypertensive patient on diuretics can have hypertension with hypokalemia. That is a common scenario, but like you told, the most important thing a postgraduate should think is hyperaldosteronism.
Yes. And patient known case of type 2 diabetes, hypertension, presented to ER with complaints of multiple episodes of vomiting since the last 4 days and had a constipation.
Vomiting will produce hypokalemia or hyperkalemia? Hypokalemia. Vomiting.
Chloride.
Hypokalemia or hyperkalemia?
Hypokalemia.
So if you see vomiting and diarrhea may not produce that much hypokalemia. It produces acidosis, loss of alkali. But whereas this produces severe vomiting and alkalosis.
Yes. And constipation, but his passing flatus since the last 2 days, along with patient generalized tingling sensation.
What do you learn from that history? Constipation in hypokalemic patient.
So in patients with hypokalemia, there will be presence of reduced GI.
Motility
will be reduced. So there will be presence.
So you told flatus is passing.
Yes.
So what you are ruling out?
So it's not a block obstructive obstipation. It's not there.
Complete obstruction is not there.
And there is no history of any fever or abdominal pain, progressive abdominal distension. There is no history of any dysuria. There is no history of giddiness while standing or headache. There is no history of weakness of limbs.
What is the importance of all these things? Giddiness on standing, headache, all these things.
So in patients with hypokalemia, they can present as postal hypotension.
Sure.
Vasodilation.
Hypokalemia will produce vasodilatation. It produces vasoconstriction. That's why you are developing hypertension.
Yes.
But he has told correctly, a patient who is having hypertension, postal hypotension is there or not, we have to check. Because he may be on some other drugs which can produce postal hypotension. So all histories are very important, but we should know why we are asking these histories. That's all.
Yes. And there is no history of any weakness of limbs or slurring of speech or deviation of angle of mouth. And the medication history, the patient is on tab metformin 500 milligram BD and also on glimepiride 2 mg OD on morning. Patient is also taking tab losartan 50 mg at morning.
What is the action of losartan on potassium?
It will also reduce, increase. Hyperkalemia.
Retains potassium.
Yes, hyperkalemia. And patient is also on tab Lasix 40 mg.
What is the action of Lasix on potassium?
Lasix will remove potassium through diuresis. And past history, the patient is having history of systemic hypertension since last 10 years and type 2 diabetes since last 5 years. And on examination, patient conscious already, systemic examination, general examination, there is no history of any pallor, icterus, cyanosis, clubbing, lymphadenopathy or pedal edema. Systemic examination, patient on per abdomen is soft, non-tender, bowel sounds are present. And CNS, there is no presence of any focal neurological deficit and chest is clear. CVS S2 and S2 are normal. And initially patient had complaints of vomiting and multiple episodes of vomiting. So we gave injection pantoprazole 40 mg and we also give...
what is pantoprazole to do with vomiting?
We initially gave because the gastritis could be one of the reason of vomiting. So that's why we gave it as a prime.
Acid secretion.
Yes, increased acid secretion. And also we gave injection
Antiemetic.
Yes, antiemetic. Injection MST 4 mg was also given. After that, we have taken an X-ray rectal abdomen. This patient had a history of, now gives a history of constipation since the last 2 days. So we took an X-ray rectal abdomen showing no airflow levels with lower colon. Okay. And initially itself, we gave an enema and we also gave the potassium correction. So potassium correction is...
How do you give potassium correction?
Potassium correction, ideally in this patient, we should arrange.
So that's why we need to know what is the amount of potassium required in his body.
Yes.
So 200 you have already calculated. What is the daily requirement of potassium? What is your daily requirement?
50.
Daily requirement. 1 milli equivalents per kg body weight.
Yes,
So this patient may be 60 or 70. Additional 70 you have to add. So 200 is a deficit. Additional 70 is the daily requirement. So he may require around 240 or 260, 270 milliequivalents. So definitely you need to put a central line in this patient. If you can give peripheral line, you can give maximum
Up to 40.
up to 40
milligrams. In this patient, we told to arrange for a central line, and initially just started with correction for with 40 milliequivalents potassium correction, or in 1 pint NS over 6 hours we had initially.
Where will you give correction, like quick correction? Here, even if you don't put a central line, see, in clinical practice, even when we are telling all these things, some patients, if you give 40 milliequivalents as through peripheral line, patient will improve. Where all you must correct it fast with the help of central line.
So in case of patients having ECG variation showing tachyarrhythmias.
Okay. ECG variations are very important. Then
And also if
second thing,
respiratory
difficulty in breathing, muscle weakness, paralysis.
Yes.
Okay. So these are the two conditions you need to correct, like whatever is given in books. Okay.
Yes, sir.
Otherwise, even if you take some time, nothing will happen to the patient. Paralytical ileus, muscle weakness, diaphragmatic weakness, and ECG changes. These are the conditions we have to correct it fast.
And so after that we did the lab routine investigations also, and with showing a procalcitonin of 0.1 with the urea of 25.9, creatinine of 0.6, magnesium of 2.1, and sodium of 132. Potassium lab was 2.
Magnesium is 2.1. That is normal.
Yes. And
Is it important in
yes,
hypokalemia?
usually in hypokalemia we expect
If the
hypomagnesemia.
patient is losing through urine potassium, then magnesium also important. Magnesium loss and potassium loss through urine occurs simultaneously.
Yes. And patient is having a sodium of 132, HB of 10, platelet count of 209,000, CRP of 12, and
What is urine sodium?
urine sodium is 6.
Is that important or not?
Urine potassium.
Urine potassium.
Urine potassium was 8 milliequivalents.
8 minutes.
8
So what
milliequivalents.
does it mean?
If it's less than 10, it means that it is not due to the urinary loss of potassium. It could be due to GI loss or
Okay.
other.
If the potassium loss is less than 10 in urine, that rules out urinary loss of potassium, and some diseases like Cone syndrome and all can be ruled out.
Yes. If urinary potassium is more than 20, we can. It could be the reason of a renal loss. And if a patient is having an associated hypernatremia also, it could be due to a hyperaldosteronism or even massive GI loss.
Okay.
That can also lead to at least urine potassium. If patient is having a spot urinary potassium less than
So aldosterone retains sodium, removes potassium. Okay.
yes. And if patient is having the spot urinary sodium, urinary potassium less than 10 milliequivalents, it could be also due to reduced potassium intake, or it could be due to GI loss, sweat loss, or NG tube suction. That can also lead to this problem. Transcellular shifts, and also alkalosis or hypomagnesemia. And hypokalemic periodic paralysis or thyrotoxic hypokalemic periodic paralysis can also. And
Here, what is the reason for hypokalemia?
this could be the reason of increased GI
Vomiting,
severe vomiting.
Maybe the reason for hypokalemia.
Yes, sir.
And requirement is around 260 or 270 milliequivalents in that 24 hours.
Yes, sir.
You definitely require a central line to correct this. If the patient is clinically fully stable, then you can depend on first 40 milliequivalents, then you can give ringer lactate, oral potassium. Oral potassium, how do you replace? How do you replace?
We can give it by oral syrup form, or we can give it through dietary intake through fruits, like patient having banana,
What do you give?
then coconut water.
Lime juice is the best thing, because tender coconut again contains glucose, that also contains good amount of potassium. The lime juice will be the better choice for all patients and stable who are stable. Okay. Pot chlor is another preparation, the potassium chloride solution that also can be used. That has got side effect like
Gastritis.
severe gastritis
Gastritis.
can be there. That we have to keep in mind. Okay.
So, basically what hypokalemia. So hypokalemia by definition means a potassium value which is less than 3.5 milligrams per liter, and causes could be various causes. Initially, it could be a reason of transcellular shift. Transcellular shift mechanism mainly in cases of alkalosis, or if patient is having an increased plasma insulin.
So alkalosis can produce hypokalemia. Hypokalemia itself can produce alkalosis. Both are possible.
Yes, and increased plasma insulin levels can also.
So when you are giving high dose insulin, especially in diabetic ketoacidosis and all, patient can somebody is having hypokalemia, it can further deteriorate because of the transcellular shift. Even dextrose also can produce transcellular shift.
And also beta agonists.
Beta agonists.
Beta like salbutamol can also produce potassium transcellular shift. And then by hypokalemic periodic paralysis, congenital form, and also in thyrotoxic form. And patient other causes due to
how the patient develops periodic paralysis? What are the clinical scenarios? Hypokalemic periodic paralysis. How do they present to you?
Heavy diet of food.
After heavy glucose diet, carbohydrate diet, they develop transcellular shift. Okay.
Yes. And other cause could be due to decrease in food intake, then as in case of fasting, and also if patient is using alcoholism,
Okay.
and a patient, it could be worsened by hypomagnesemia if patient is with alcoholism, and also eating disorders with patient is having increased history of vomiting by self, and GI loss in the form of vomiting, and also NG suction, and also diarrhea can also cause hypokalemia, and mainly in the reasons of like using enema or laxative abuse, and also malabsorption syndromes, and also ureterosigmoidostomy procedure can be, or enteric fistula. And renal loss is mainly by the form of diuretics, carbonic anhydrase inhibitors, loop diuretics, or thiazide-like diuretics, and primary or secondary hyperaldosteronism.
Very good. Secondary hyperaldosteronism. Primary concern. Secondary. Every day you are seeing the case here. Cirrhosis. Cirrhosis is the most common cause. Cirrhosis, chronic liver failure. One of the reason for edema is secondary hyperaldosteronism, and that itself will produce hypokalemia. Hypokalemia can aggravate
hepatic encephalopathy.
So it's a cycle.
Yes. And so increased usage of tobacco, renal tubular acidosis, and even presence of Barter's syndrome and Gittelman syndrome.
Bartter syndrome.
Yes. And
They're all potassium losses through
kidneys, renal loss, and or mineralocorticoid excess syndromes like and Liddle syndrome, and drugs or toxins. Usually, if patients is using an antibiotics like aminoglycosides or carbenicillin, penicillins, and even Parkinson's medications like Syndopa or chloroquine, theophylline, drugs can also cause hypokalemia, and through sweat loss, heavy exercise, and heat stroke, and even fever can lead to hypokalemia. Other causes may include hypomagnesemia, and also leukemia or lymphomas or hypothermia. And usually the clinical feature, usually they can be present with various signs and symptoms. Cardiovascularly, they may present with hypertension or orthostatic hypotension, or presence if patient is using digitalis, it can precipitate the digoxin toxicity, and also a patient
What
can.
is the sign of digoxin toxicity? Reverse tick sign is a digoxin effect, not toxicity. Arrhythmias, especially AV blocks.
And dysrhythmias, usually tachyarrhythmias can be formed, or T-wave flattening, U-wave, or presence of ST depression can be seen in a ECG changes. The neuromuscular changes mainly could be due to malaise. There will be presence of weakness, fatigue, and hyporeflexia, muscle cramps, and also paresthesia. Even last can move to paralysis. And GI mainly symptoms could be nausea and abdominal distension, and EDS can be the symptoms. And renal mainly in case of like patients in hepatic or patients, there will be increased ammonia production also, and urinary metabolic alkalosis, and also there will be presence of nephrogenic diabetes insipidus. And endocrine, usually glucose intolerance can also occur due to potassium loss.
What happened to this patient afterwards?
So this patient was admitted, and like the potassium corrections was given and symptomatically managed for the acute gastritis, and it was discharged.
Okay.
Yes.
Thank you.